All right. Hi, everyone. Welcome back. Today we have a great speaker. Dr. Arash Alavi is here. Arash is a computer scientist and he's a research and development lead at Stanford School of Medicine. I have had the privilege of knowing him since 2018, and we have been working on several large scale projects, including my PhD, alert systems, swarm, SDO. So, first of all, thank you so much, Arash, for being here. Tell us a little bit about yourself, and that being said, hand it over.
Sure. Thank you so much, Amir. I'm Arash. I'm a computer scientist at Stanford School of Medicine, and I got my PhD in computer science in 2019, and then joined Stanford as a computer scientist and worked with Amir, as he said, on several projects around precision medicine. Today we are going to talk about mHealth in precision medicine. We'll talk about the current challenges in healthcare industry and how mHealth can address these challenges. If we want to summarize the mHealth story, the story of mHealth, we can say that healthcare can leave the building, or even in many applications, maybe it has already left the building. So that's the idea behind mHealth. In today's lecture, we'll talk about why mHealth is important and what are the current challenges that are facing the healthcare industry and how mHealth can address them. We'll go over the mHealth architecture and then we'll talk about security and privacy in mHealth because that's one of the fundamental things when you deal with medical applications. And we'll talk about security threats, goals, and standards, whether like solutions, and then we'll talk about penetration testing on mHealth apps because that's where you're dealing with a lot with mobile applications. And then we'll talk about the state of the art technologies. We'll give you two examples like mobile health APIs and edge computing. And then we'll talk about an example of mHealth, Stanford Personal Health Dashboard, as I mentioned, the PhD platform. And then we'll talk about one of the examples, a night signal algorithm, which is a precision real-time infection detection algorithm using wearables data. And at the end of the lecture, we will have a demo on the night signal algorithm in SDO. What are the current challenges that are facing the healthcare industry? If we want to list the challenges, the first one is cost. The U.S. national health cost grew almost 10% to $4 trillion in 2020, which equals to like almost 20% of GDP, which is a huge increase in cost. The second reason, challenge could be shortage of clinicians. So it has been estimated that within 12 years, there are 10,000s to 100,000s of shortage of clinicians, which is a real risk to patients' life. And the third one is response time. Most of the procedures in healthcare industry it's a time-consuming process, like scheduling appointments, diagnosis, treatment, paperwork, everything. So you have delayed in your response time would not be real time. The real time solution would be the ideal solution. And then we have hospital visits. So as you increase the number of hospital visits, it would increase the risk of contagious disease like COVID or even patients' costs or hospital costs and so on. So these are just some of the examples. And mHealth actually can help addressing almost all of these challenges. Um, this is the mHealth, the overview of mHealth architecture. Next to the users, we have mobile applications, and then we have wearables or biosensors, and then we have hospital clinical data like EHR. The first layer is basically data sources, and then we have data, which is again wearables data like your heart rate, your steps, your sleep analysis data, and so on. And could be like survey questionnaires, your medical information, historical medical records or EHR data, and so on. And then we have analysis, which can be offline, or you can have a real time or online analysis. And then we have the applications, which again could be, for example, at the core level application, or it could be personalized and individual level. So, but the ultimate goal is the precision medicine for the mHealth basically platforms. Um, so we have different types of mHealth apps. The first one is like health commerce apps. So these are like pharmacies or companies that they're trying to selling their like products or refilling prescriptions and so on. And the second one is medical and wearable device apps like Fitbit, Apple Health app, and my PhD, the personal health dashboard app that we'll talk about at the end of the lecture. And the third one is telemedicine and patient engagement. So these are for evaluation, diagnosis, and treating patients remotely. And then the last one is tracking apps, like for example, for COVID-19 tracking. And so in terms of applications, you see that they are being used for collecting clinical and health data or wearable data, real-time monitoring of patient health, or direct provision of care, like in terms of telemedicine or telehealth. So telehealth is more broader. It can be used for non-clinical purposes as well, and health data sharing for researchers. And the number has grown a lot, right? So the percentage of patients using telehealth apps, for example, back in 2019 was only 10%, especially because of COVID. It grew to 40%, over 40% back in 2020. So now we'll want to focus on security and privacy in mHealth, which is again the foundation of any app, especially when you are dealing with medical and health applications. So let's just start with this question: that which industry do you think is the number one target for cybersecurity attacks? So the answer is healthcare. Data breaches and ransom attacks last year alone cost the healthcare industry an estimated $4 billion only for ransom attacks. So, and one of the examples is like Garmin. If by any chance you had a Garmin watch, you might have noticed that it was working for like 2 weeks. It was not working at all because they didn't have access to any data. So, speaking of ransom attacks, it's always a debate between the security experts and the companies. So, security experts, they often suggest do not pay the attackers because that will be a motivation for next attacks. But on the other side, companies, most of the time, they have to pay because otherwise it would be the end of the company. Um, so, in terms of security and privacy in mHealth apps, this is a good security report on mHealth applications back in 2020. You can get the report from the link. And so they did a penetration testing on 100 top mHealth apps using the OWASP security guideline that we'll briefly talk about that later. So they found serious vulnerabilities, like 70%, almost 70% of apps had at least one major and high level, high risk vulnerability, or 90% of mHealth apps fail cryptographic tests, which is a big number. So, or 85% of apps, COVID-19 tracking apps leak some sort of information. Um, so these are serious vulnerabilities. So in next slides, we'll talk about what are the actual threats and what are the vulnerabilities that can happen in mHealth applications, and then we'll talk about what are the goals for as if you want to develop an mHealth app, and then finally what are the solutions or standards. So speaking of security and privacy threats in health applications, this is the mobile attack surface with respect to different aspects. So first of all, for data address, you need to make sure that every single data is encrypted on your phone, whether you have an iOS or Android app, using key store or keychain with respect to the standard key sizes and so on. You need to make sure all the credentials and sensitive information is encrypted, stored on the local side, like your SecureLite database. And then for data in transit, also you need to make sure that end-to-end you have encryption, end-to-end encryption, whether you're using SSL or TLS, whatever secure channel, SFTP or FTPS, you are using whatever secure channel. you need to make sure that you follow the standards and best practices in terms of making your data end-to-end encrypted. And permissions is another one that you need to make sure that you have least privilege access and permissions. You don't have any unintended permissions in your app. And one of the other very important aspects of the mobile applications is code functionality, the quality of your mobile app code. So that's where many of the mobile attacks happen in terms of reverse engineering attacks. So you need to apply a lot of like techniques and defenses like tamper detection or code obfuscation or root detection. And for all of them, you have several choices, and it's better to have multiple security layers. So if the attacker breaks one of them, you have the next ones to be there. And another one is APIs. So whatever APIs that you're using for your data collection, for analysis, and so on, you need to make sure that you apply the best practices against, for example, brute force attacks or DDoS attacks. But for APIs, some parts of that is happening at the phone level, but most of the part is on your server side. For example, against DDoS attack, you might have some authentication mechanism that some part is in on the app. For example, you might have captcha or waiting time or IP blocking authentication mechanism, and the other parts are mainly on your server side, whether you're using cloud or any HPC server service and so on. So another question, in which security and privacy threat you think the mobile app is not the major attack surface? So that's the final number. Yeah. So we have 43% interest, the code obfuscation, and 25% in authentication and basically SQL like they're changing. Okay. 40% for code obfuscation and 20% for A, B, and C. And the answer is actually C, authentication policies against DDoS attacks. So as I mentioned, like for authentication policies, like against DDoS attack or brute force attack, some part of that is happening at the server side. But like tamper detection or code obfuscation is all about your code, your app code, or even like permissions or SQLite, which is a local data storage for your app. But for authentication, most of the part is happening at the server side. Even if there is an attack, there is a DDoS attack, it's usually against the server side. So now, what are the security and privacy goals in mHealth applications? So we can talk about CIA triad as the fundamental of any security system, including mHealth applications. So we have confidentiality. Confidentiality means that the data should not be accessed by any unauthorized party. So it's all about read access. And integrity on the other side is about changing data. So data should not be changed or modified during data transit or data at rest. And the other important thing is availability. So your mobile app or your system or service needs to be accessible whenever you need it for that job. So the reason that's part of the security model is that you can have a super secure system, like a secure PC, and you just put it in a room, lock it, nobody have access, maximum security, but that's not really secure. Your system should be only secure if it's available when you need it for that job. So that's why the availability is also part of the security model. Uh, so I think we have another question. Which of the following is not considered as a violation of confidentiality? Right. So 60% hardware destruction, and that's the right answer. because it's all about like destroying the system. It's more about availability and not confidentiality. But I see like social engineering. Social engineering is again about unauthorized access could be. So that's part of the confidentiality. Um, and now, what are the solutions for specifically for mHealth apps? Now that we know the threats and goals, so these are the most common standards. And the first one, the OWASP security guideline, is the most famous one and most common security guideline for medical applications and mHealth applications. But we have other options like OSTEM or OSSTMM or PTAS are the other standards. But because OWASP is more popular in this in few next slides, we'll talk about OWASP security guideline. So if you check out the OWASP security guideline, it's like a 1,000 page of security and privacy, basically best practices that you can apply on your mobile application. It has a lot of examples for iOS and Android applications, how you can securely store data and so on. So setting up a testing environment is one of the most parts that how you can uh, basically attack your app yourself to find out the vulnerabilities, to try different types of scenarios. And data storage on mobile app is another one that is covered in OWASP security guideline with many sample codes, authentication and authorization, and again, reverse engineering attacks as one of the most important parts, like tamper detection or root detection and even code obfuscation techniques. So in terms of like setting up an environment, you have several tools and APIs and libraries that you can use. Like, and in we won't definitely go into details, but for example, for Android, you can use Android Studio, AVD Manager, or emulators. Maybe you might need to make sure that you have routing access if you are using emulators, because that's how most of the attackers would do. And then the ADB Manager or APK tool. So those tools, basically what they do is like they decompile your code back. For example, when you have an Android app is in Java, it would decompile the code back to some other intermediate format called, for example, a Smiley code. And in a Smiley, for example, you can change the logic of the app, and then you can repackage the app again as a malicious version of your app, and just put it out there, and people would use the malicious version of your app. For example, a simple example could be you just change a URL that some sensitive information is being sent to that URL. You just decompile the code, the APK file of the app using APK tool or text to jar or any decompiler to a Smiley code, change that link, repackage the app, and send it to the stores, and people would use the malicious version of the app. So there are a lot of different techniques that you can use. Again, tamper detection and code obfuscation would be useful for this scenario, that any change to your app, it would be terminated or it would be identified. And you can have, again, multiple layers of them. And there are different techniques like taint analysis, slicing, that is being used not only by the attackers but also for, so it's just a game between the attackers and like the security experts. So they find new things, and then the attackers find the solution, and vice versa. Uh, so in terms of penetration testing for mobile health applications, uh, there are different frameworks that you can use. These are like some of the examples, but most of them they would charge you, and it would be thousands for like, and it would be a time-consuming process as well, because you need to make sure about the criteria of the testing with that company and so on. But one of the most common and one of the best penetration testing frameworks that is also suggested by the OWASP security guideline is Mobile Security Framework, which is free and open source. And in next few 3 slides, we will talk about how these basically all of these mobile security frameworks are working, and the foundation of all of these are program analysis. That will give you some simple like static and dynamic program analysis examples. We won't go into details, just touch it a little bit. So in terms of program analysis, this is what basically the penetration testing tools are using. So assuming that you have a simple program like this on the left side, so you can create a program flow from your program, and in program flow, every node would represent the line of code, and then the flow would be either you would have data flow or control flow edges. So the edges, which is data flow, means that in your program, you always have definitions and then you have users. So for example, on the line one, you define X, and then on line two, you are using that X. So that means that node two is data dependent on node one because there is an X which is being used on node two, which is coming from node one. And this is basically the flow. And whenever you have a branch, for example, in program flow in your program flow, for example, on line three, when you have a while loop or if or for loop, there would be a branch that basically decides which direction your program is going. That's why you have like a branch like this here. And then from your program flow, you can create a program dependence graph that again, the nodes would be same, again, each line of code. Uh, but the edges here are two types of edges, data dependency and control dependency. So data dependency is the same as this one, like def use chains. So for example, two depends on one because there is an X on two, which is being defined on node one. Or for example, three is also depends on one because there is one X here, which is defined on X. T also depends on two because there is a Y here being used and it has been defined here. So the solid edges are basically data dependency that is defined based on this def use chains. And then we have contour dependency, and contour dependency is because of these branches that we have in our program. And that means that the execution of that node depends on the other node. So whether this node 4 or 5 should be executed depends on the decision that we make on node 3. So that's why both of them, both 4 and 5, are contour dependent to node 3, which is this basically dotted edges. So these are two types of data dependency and control dependency, two types of dependency in program dependence graph. And then once you have your program dependence graph, you can have two types of analysis, static analysis and dynamic analysis. So in a static analysis, this is again one example that you have program and you create this program dependence graph from your program. So static analysis means that you look to all of the possible scenarios, even impossible scenarios. Like in real world, those scenarios cannot happen. But you look at everything. And that's why static analysis is prone to false positives, because you might consider some scenarios that cannot really happen in real world. For example, let's say, for example, this n cannot be really above 100 in real world. It's impossible, but you still consider that as a possibility. So static, but the good thing is that the static analysis would have a huge picture of your program. You will look at every single possibility. Um, but on the other side, we have dynamic analysis on the program dependence graph that you consider specific executions, a specific criteria. So you always define a criteria for your dynamic analysis and you run your program and then you see that, okay, what's going on. So for example, for this example, we give some specific number to n, and then these are the nodes that are executed, and node number 7 is not executed. So that's not part of the analysis. We don't consider that. So this is for one specific execution, and you can have a set of executions and consider just a set of scenarios, basically. And this is also being used in penetration testing tools because, for example, they want to know what is the behavior of the app for some specific scenarios and some specific inputs, for example. And this is just a quick demo of the mobile security framework to just give you an idea how does it work. So as an input, you can give there is a great documentation on the GitHub page how you can do the static analysis, dynamic analysis for both iOS and Android apps. So you can give the application file, whether it's IPA, iOS IPA file or Android APK file, and using the local host, you can see a whole picture of your application. For example, in Android, as some of you might know, we have activities and services and receivers and providers. And then it will show you all of these components. It will look at all the possible vulnerabilities, running the static and dynamic analysis. For dynamic analysis, you can also run the emulator and give some specific execution, specific scenarios to the tool. And it would find out all the possible vulnerabilities with different tags. Even if you have some sort of like security defenses or protections, it would tag it as a secure tag, for example, that it would identify basically those security protections as well. And it would look for all the current CVSS vulnerabilities, known attacks, and so on. And it would tag it if there is any high risk or even medium or low risk to your app. And at the end, it would give you an exam. It would give you a score to the app. Um, that later, once we talk about Ph.D, we applied all of these like security best practices to the app, that we got the score 95 out of 100. Any score basically above 80 means the app is super secure. And many of those scenarios again are coming from a static analysis. As we said, it's prone to false positives, so those can be scenarios that cannot really happen in real world, but still the framework considers them. And in next two slides, we'll talk about the state-of-the-art health technologies. We'll talk about two examples here. So the first one is mobile health APIs. So speaking of mobile health APIs, you have three scenarios. Whether it's an app to cloud solution. On the left side, it could be also cloud to cloud, but because we are dealing with mobile health applications, we are dealing with apps. So on the left side, our side basically is an app. We assume that it's an app only. So the app cloud solution is something like, for example, excuse me, Fitbit or Dexcom. So we are talking to their cloud. So the data is on their cloud using OAuth2, for example, is one of the examples of the APIs. That is an app to cloud solution. And the second one is app to mobile OS, which is not pure mobile OS. It's kind of a, most of the time, it's a hybrid solution like an app cloud and app mobile OS. But if we assume that the data is hosted local on the mobile OS, something like Google Feed or HealthKit is like that. So it's an app to mobile OS. You're connecting to the OS API on your app, whether it's Android, for example, in Google Feed case, or iOS HealthKit. And the last one is app to a smart device. So it's app to the watch, to the smart watch or the wearable directly through Bluetooth. So you might use the SDK, the library of that specific wearable, and collect data directly from the watch. So there is no cloud being used or any OS, basically. And we might have like combinations of these in some cases, especially for the first two cases. And then the second technology is edge computing. So this is like a simple history of ID processing. So years ago, we were dealing with like client server HPC systems. And a few years ago, cloud computing started being used with many systems. And now a lot of systems are using edge computing. So edge computing basically is useful when you want a real-time analysis. So you want minimum latency, or even sometimes it might be because of security reasons. So the idea is to push back the computation as much as possible to the edges, to where the data is actually coming and to where the processes, we want the processes to be done. But edge computing is not going to replace cloud computing, because you still need to do some sort of analysis at the cloud, on the cloud. For example, analytics like aggregated analytics or cohort analysis. For example, you want to aggregate some sort of data on the cloud side. So it's kind of an optimization problem always. You want to know which process to run on the edge and which process to run on the cloud. Again, the reasons for on the edge side could be latency, minimum latency, and security could be another reason, because you don't want to, for example, collect any sensitive data. You just send aggregated format data to the backend or the cloud. But there might be some limitations in terms of the library, in terms of the computation or processes that you can done. And the mobile survey has been improved a lot during last few years. Some like different libraries that you can run different ML algorithms on the phone level, like TensorFlow Lite, all of these libraries to running machine learning algorithms on the phone, both for iOS and Android. And now we want to talk about an example of the mHealth framework, which is called Stanford Personal Health Dashboard Platform. The paper, you can get the paper from QR code if you're interested. So the paper got published in Nature Communications last year. It's an scalable, secure, and payable platform for deep data-driven health management. Uh, so this is the overview of Personal Health Dashboard platform. Again, using an iOS and Android app called My PhD. Uh, My PhD collects all of these different data, for example, heart rate, steps, sleep analysis, even glucose, or other data types from different wearables using those scenarios that we talk about, like app cloud solution, app SDK solution, and the app OS for example, Health Feed and Google Feed. And de-identifies and encrypts every single record and send it back to the cloud on GCP, specifically in this example. And then on the Google Cloud, there is an authentication cluster that can scale based on number of workloads using Kubernetes. And then there is a machine learning cluster that can schedule different types of algorithms and then send back the results to the participants using different de-identification keys and authentication authorization keys and IDs. So everything would be anonymized, basically. No PHI data would be collected, and also multi-omics data could be integrated to the backend using the same security mechanism. And this is with respect to the scalability of PhD. So as you can see, there are different load balancers all over the world that can basically scale based on the number of workloads, again, using Kubernetes. And on the right side, that's the machine learning cluster that is basically a scheduler and some pre-processing and training and inference for different machine learning algorithms. And the other good thing is that model registry frameworks such as MLflow can also be added to the system. And then the encrypted data is coming, and the data would be the result basically would be encrypted again and send it back to the participants. But again, speaking of the edge computing right now, we can run some of the algorithms at the phone level. For example, the night signal algorithm that we will talk about at the end of the class. We're running that at the phone level because that's not that's like this lightweight algorithm basically. And then with respect to my PhD security, so this is the kind of a comparison between security of PhD platform to other platforms in a component base with respect to different components like client side, the communication channels that we are using, and so on. And then on the bottom side, you see that on the left side, on my PhD, we have all of those best practices, again, with respect to OWASP security guideline. However, in some other works, it might be not fully satisfied for some of these criteria, like app protection or permissions and so on. And the other thing for security, which is important, is when you are adding any security mechanism to your system, you're kind of sacrificing other parts, like, for example, response time, because you're adding workloads to your system. So that's a comparison between like what would be the for example, in terms of this example is an fail to ban, which is for protection against DDoS attack. As you can see, once we have failed requests coming, then it would be it would be some number of workloads would the number of workloads would increase, but as the system get stable and we have blocked with respect to that authentication policy that we have. So for example, here we have a waiting time policy, so we will block the IPs for, let's say, for example, 12 hours. And during that time the system is stable, so it goes back to the normal CPU utilization and the number of, with respect to number of requests. And the second part is the real-time alerting system for COVID-19 and other stress events using wearable data. Again, the paper got published in Nature Medicine. You can get the paper from scanning the QR code. So using the PhD app, we basically created this real-time alerting system and a new algorithm called Night Signal that will have a demo at the end of the uh, class. So this is again using the PhD platform. We are collecting different types of wearables data from Fitbit, Apple Watch, all of these different wearables, and security transfer these biometrics, which is mainly heart rate and steps, and we are also collecting sleep data and some survey events, which is being used for validation of the algorithms, and then the running three algorithms on the backend: online night signal, RHR anomaly detection algorithm, and the QSUM statistical model, and then sending back the results in terms of alerts to the participants on the phone level, which is like green and red alert. On the night signal demo, we'll go over them. How do we generate these alerts? But this is, for example, one of the COVID positive cases that basically, as you can see, that 3 days before symptom onset for this COVID positive case, the alerts are generated, so it can be the user could be notified before even symptom onset, and we have another asymptomatic case on the next slide. So as you can see, for consecutive days, the resting heart rate has been deviated from the baseline. Again, we'll talk about how do we create this baseline and calculate the baseline for each individual. And then this is an example of an asymptomatic case. As you can see for this one, like over a week, we have consecutive red alerts and deviations from baseline, even though that the person was asymptomatic. Because again, heart rate as one of the first physiological changes when someone is getting infected could be used, but other types of data like temperature, blood oxygen, like SpO2 or heart rate variability could be used as well. And we also compared the performance of the night signal algorithm to other algorithms. The resting heart rate anomaly detection, QSUM, and isolation forest as one of the basically popular anomaly detection algorithms for time series data. And the sensitivity was 80% and specificity of 88% for the night signal. And also another good thing was that at the end of the study, we asked the participants about their experience to the study, and 73% of the participants they were satisfied with the number of alerts that they were getting, and 21% of participants they were saying that they are getting less number of alerts than expected. For example, they had a stressful event that they expected to see an alert, but there was no alert for that day, and only 6% of participants they were getting more number of alerts than expected. And this again, this is not only for infectious disease, could be used for any sort of stress events, but for a case of COVID, like especially for severe cases, we see consecutive deviations from baseline compared to a single, for example, event, something that like a stressful day or something like that. It's just 1 or 2 days effect. And right now, we'll go. Sure.
How long did it take for us to create nine?
Yeah, I think that's a funny story. I think it was a Friday night. Amira and I we started working on that nonstop till Sunday night, like 48 hours, and we ran all the analysis, everything, and yeah, that was a that was a funny weekend. So yeah, and right now we are actually improving the algorithm. in terms of making that more customizable for personalized, basically, with different thresholds for different people. So even the participants would be able to personalize their algorithm themselves. So to whatever sensitivity rate that they want the algorithm to be. For example, someone working at healthcare, they can put it to be super sensitive. So whenever there is a small thing, they can be alerted as soon as possible so that they can do actions. But again, there are a lot of things going on with IRB and so on. So we are not allowed to suggest anything. It's not kind of anything FDA approval, but again, it has been um, at least published in Nature Medicine, so it could be used. Yeah, it's the first one. So now I would like to show you a quick demo. Okay, great. So I'm not sure if people online can hear me because I'm not sure if is it going to be on chat. Okay, great. So this is the night signal algorithm. Not sure if you're trying to on your side, but this is the night signal algorithm notebook on the SDO platform. So the first part of the code is just to give you an idea of different parts of the code. So it's the pre-processing of data. Again, as we mentioned, we are working based on heart rate and steps data. So using the heart rate and steps data, we calculate the resting heart rate. And the way that we calculate that is like any heart rate data point that the corresponding step data is zero, we consider that as a resting heart rate. And then we consider resting heart rate overnight. And the reason of that is to just filter out other resting heart rate during day because of a stressful event. For example, you're just on a Zoom call, your step is zero, but you are under stress. So just to filter out those, and overnight would give us a more pure resting heart rate, especially for infectious disease. But for other stress events, definitely other data types during other periods of day would be useful too. That's what we are using for the new algorithm, like for different time windows during day, like morning. You can even the user would be able to choose like different time windows: morning, afternoon, evening, and so on. And then we create the baseline basically for each participant. And the way that we create a baseline is based on median of average of those resting heart days for that day. And then, with respect to a deterministic finite automata or state machine, we generate these alerts. And the way that we generate them is, again, this is the state machine. So we consider, for example, this one would be the state zero. If the resting heart rate overnight is not above with respect to a threshold, so these 3 and 4 thresholds that we are using here is based on the tuning. We did the tuning using our phase 1 study, which we had 2 offline algorithms for this online algorithm. So the 3 and 4 are coming from the previous data set, previous COVID positive cases that we had for phase 1 of the study. But if it's not above that basically threshold, we consider that as a normal or green zone. So you're still on this state. But if it goes above the threshold, whether it's going 3 point above or 4 point above, depending which one is happening, we go to either state 1 or 2. So if it's only 3 basically point above, we go to a state 1. But if it's more than 4, more than or equal than 4, we go to a state 2. And then from a state 2, again, if it's more than 4 for the next night, so that's one of the most kind of important concepts, that we consider 2 consecutive nights for this deviation, because that's what's happening in like infectious disease, especially COVID. Because if it's just one night, for example, you might have some specific event during a night. You might have different types of stress events that can increase your resting heart rate, uh, uh, like even traveling or alcohol or menstruation or different types of activities that can just deviate that for only one night. So that's why we consider 2 consecutive nights for the algorithm. And then after again depending on this threshold, whether it's 3 or 4, if it's 4 points above the baseline for 2 consecutive nights, that's going to be a red alert. But if it's only 3 point above, then we go to one of these two states, basically yellow states. So here again the state machine is based on 3 phases: green, yellow, and red. But because of IRB approval, we were not allowed to send green and yellow and red alerts to participants, because it would increase the sensitivity, and red might be kind of people might uh, get anxious about the red color versus green and yellow, because you're adding weight to your results. So we were only allowed to send green or red, like normal or abnormal. So we transferred basically the way that we handled that in on the study for participants. We changed the yellows to it's possible to change it to both green or red, but this is like a tier version, which is green and yellow and red. So in terms of the code, these are just some helper functions, and oh, sure. That weekend. I think so we were using basically anomaly detection algorithms and then statistical model. But this one basically, again, because we look at the trend of the resting heart rate for this COVID positive cases that we had for phase 1, we had over 30% for 30 people for COVID positive cases. And we look at the trends, and we saw that the data could be aggregated. And then I think the first thing that came to our mind, we learned that from our CS classes. So it was a state machine. So we were thinking that that could be a good map to a state machine to send in this real-time alerts again, whether normal or abnormal. But here, because we started with 3 states, we created this, but then we converted that to a state machine, basically. And the infection period, exactly. And then that's why we also consider that 2 consecutive nights as well. And so for the code, we have, these are just some helper functions. And so again, the baseline that being used is median of averages, average resting heart rate overnight. Basically the first part of the code, these are just some directories that are reading the data, the input data, which again is heart rate and a step. So non-Fitbit means like it. Most of the cases, it's like an Apple Watch or Garmin. It's like a health kit data. Could be Apple Watch or Garmin, and Fitbit data are like this. And then these are the participants' IDs in this list. And this is like running the code for all of these subdirectories inside the actual input directory. And then we have 2 sections. One is for Fitbit and the other one is for Apple Watch. Again, the only difference is the resolution of data. So for Fitbit, the resolution of step data is per minute. And for Apple Watch, it depends on your activity, your heart rate resolution and step resolution. But for Fitbit, the heart rate is a few seconds, and the step data is per minute. Then once we do what we do here is we create this resting heart rate, again based on whenever the step data is the corresponding step minute is 0, we consider that heart rate value as a resting heart rate. And then once we have this resting heart rate result or file, we calculate the alerts that basically based on the averages. First of all, we created the aggregated data for each day using the averages, and then we created the baseline using the median of average of resting heart rates. And also we have an imputation, and for imputation we get the average from the night before and the night after, and we just do that for one night. Again, this is something that we did by analyzing the COVID positive cases. And this actually helps us. This would delay one night, right? Because we don't have one night, and then the next night that we have it, we can do the imputation and see what was the result for that night. But still, it helps for some of the COVID cases. It might be, for example, instead of 4 days before symptom onset, it might be 3 days or something like that. But if it's more than one night missing data, we don't do any imputation, because we have seen in few COVID positive cases that the resting heart rate is only deviating for 2 nights, but it's deviating a lot, but it's only for 2 nights. So if that's the case, if that 2 nights is missing, you're just missing the signal. So it doesn't matter to do the imputation or not. And then after handling this missing data, again, using the baseline, we create this, which we are using median of averages for baseline. We create the baseline, and then finally we create this red and yellow based on the deterministic finite automata and thresholds. And I think these are all like, again, the first of all, we create the potential yellow and reds, and then with respect to that consecutive nights and the state machine, we create the actual red and yellow um, uh, alert files. And the similar thing for Apple Watch, but for Apple Watch, the only thing is, again, differs is the resolution. So first of all, we resample them to the minute level, and then we do the same analysis as we did for the Fitbit data. And but again, we put them as separate, so it's kind of clear that we are doing same, but it could be merged into one function too. And then the last part is just plotting. So that I'm just this one's. Let me know if you have any question, but these are like just for plotting purposes, and mainly for like with respect to the format for the paper and so on. So this is going to be the final result. That, for example, whether it's COVID positive case, and you can if you look at the basically the paper, these IDs would be some of them might be COVID positive cases. You can compare that to the actual paper data set of COVID positive cases that we have on the Nature Medicine uh, uh, link. But this is going to be like, again, especially this case like of consecutive red alerts, that for 1 or 2 nights we don't have a red alerts, and then we have some red alerts. This kind of behavior, we have seen that in many COVID positive cases, because of medication or resting. Sometimes we have, that's what we call them, double bumps. So we have two bumps, basically, one for 2-3 days, and then decrease, and then an increase again. Uh, and finally, uh, yeah, you can, the results would be in JSON file. 0 indicates green, 1 indicates yellow, and 2 indicates red on the result file, the JSON file. And again, if you compare that to the data on the paper, we are converting this yellow files to uh, uh, to red alerts, basically. So that's because, again, for the IRB part. Um, I think that's it.